Hello, friends. A very good day to all of you out there, and a very, very warm welcome from the entire team of RFA Theaters. Is my voice audible and clear to all of you out there? Hello, the voice is clear to all of you. Hi, Thum. Good to see you, my dear. Hello, Fatima. Hi, Mother B. Hello, Samin. Thank you so much, Nirmeen. Missing you so much. Hi, Akansha. Good to see you,
Hello,
my
ma'am.
Thank you very much. Warm welcome. I hope this coaching series had been amazing. Starting from Safa Murdula and Gori, back to back, you guys have been discussing wonderful discussions on the stations, the expected stations for exam. And I'm super proud of you guys, the way you guys are learning. And once again, we are here with the continuation of the same. What is the topic for today? Are we doing the new Green Top guideline? Thank you so much. Yes, the most expected station we are going to touch today. I am expecting this station in November 2025, and I have reasons for that because it's a recent update. We never had a thyroid green top guideline, and first time ever the college has released. We are expecting the exam stations for the November exam from both hyper and hypo. Let's see how it goes. But I want you guys to be super prepared. I will take very minute points for you guys to learn from today's session. Moreover, I've tried my best to make your memory better, to tell you that how we have to be organized and how we can make it a success. Thank you very much. Thank you so much. So we are here with the presenter. Um, Am I right, Maninder? You were presenting today? Hello.
Yes, ma'am.
Perfect. Can I have your camera?
Ma'am, it's on already.
Is it? Can you speak again? Let me check it out.
Um,
Oh, yes, I can see you. All right. Can I have my lovely Cami, the role player here? Hello, Cami. How are you?
Hello, hi, can everyone hear me?
So much. So good to see you, my dear. Thank you so much for your help. So, Maninder, we are going to
Yes,
have
ma'am.
2 minutes reading time. And
Okay.
after 2 minutes of reading time, we are going to start the station. You can read up, you can make your notes. I would really like to see that what you have analyzed in 2 minutes. In fact, I
Okay,
would
ma'am.
like to see those points which you have written in the end when I'll give the feedback. And here we go with the reading time. Everybody, please be on the mute mode. Note down your points yourself. I want pin drop silence for 2 minutes. Thank you so much. 10 minutes, they start now.
So, hello, I'm Dr. Maninder, one of the doctor in high-risk obstetric unit today. May I confirm your name and age, please?
Yes, I am Annie Jones and I am 36 years old. You can call me Annie.
Okay. So, Annie, as I can gather from your case note that you're pregnant and you are here to discuss regarding your condition as well of thyroid disorder. Is that be fine?
Correct.
All
Yeah,
right.
that's correct. Yeah,
Okay. So, before discussing about your condition and pregnancy care, I will be asking you a few more questions related to you to know you better. And for that,
yeah,
after that, we will be coming to a safe, acceptable plan for you. Will that be fine?
that's perfect. Thank you, doctor.
Okay. So, Annie, before the consultation, I would like to inform you that my consultant, as I can see, my consultant was supposed to see you today, but due to some unavoidable circumstances, she's not there today. Actually, she has briefed me everything about you. And if you allow me to continue with this consultation, I will be discussing all the points and will book a consultant appointment as soon as possible for you. How does this sound?
That would be perfect. Thank you.
Okay, so tell me more about your pregnancy.
Okay, yeah, so I am 8 weeks pregnant at the moment.
Okay,
As my pregnancy was confirmed by a pregnancy test at my GP.
okay,
And my GP has sent some blood tests, which I think you have analyzed, and maybe you can inform me
okay,
a bit more. But I'm a bit concerned because I have been diagnosed with the thyroid problems in my
okay,
past, during my past miscarriage. I have had two miscarriages so far.
okay. I'm so sorry to hear this.
Thank
Uh,
you.
Okay. And how far the pregnancy till now? Like, are you feeling any general sickness or nausea, vomiting?
So far, no other symptoms. No, no. But as I
Okay.
said, I'm really anxious about this pregnancy because of the
Okay.
previous history. Yeah,
Okay. Don't worry, we will be taking good care of you in pregnancy. Okay.
thank you,
And
doctor.
apart from this, are you taking any medicines like folic acid in routine medicines in pregnancy?
Folic acid has been started by my GP.
Okay. Okay. Just want to ask, like, any ultrasound scan done till date for your pregnancy?
Uh, no, my GP just confirmed my pregnancy test and they have referred me to yourself to further assess.
Okay, okay. Don't worry, we'll be taking good care of you. Apart from this, I just want to know in a bit detail about your thyroid problem. Like, since when you know came to know about your thyroid problem?
As I said, I've had two previous miscarriages. One
Okay,
in a few years back, maybe 2023. I was 7 weeks pregnant,
okay,
and a second one was in 2024. I was 8 weeks pregnant, and due to the recurrent miscarriages, some investigations have been done, which led
okay,
to the diagnosis of this thyroid problem.
okay,
So I am currently taking a medication for that. Yeah.
okay. Can you just name me the medicine for me?
Yes, it's L-troxin, and it is
L-troxin.
50. I'm not sure it's milligrams, micrograms. Yeah, it's 50. I know
Okay.
it's 50 dose. Yeah.
Okay, okay. I will definitely note this down in my notes. Apart
Mm.
from this, I want to ask like any special doctor on for which under whom you are under follow-up for this thyroid problem?
No, there is no specialist input so far. Only my
Oh,
GP has sent some bloods, which I hope you can interpret for me.
okay. We'll be connecting you with the specialist doctor as well, okay, in pregnancy.
Thank you.
Apart from this, are you feeling any lately any heat on intolerance or weight gain, weight loss, or shaking of your hands or upset tummy frequently on regular basis? Any of the symptoms?
No, 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 no,
Okay.
not really.
Okay.
But
When
based on the blood results, doctor, what are you suspecting in terms of the thyroid problem?
okay. Annie will be discussing in a while. Just give me 5-10 minutes. Okay.
Mhm.
So I want to ask, like, when did you last visited your doctor GP for this thyroid problem?
Only now that I've been referred to you. Yeah. And they've
Okay.
just recently sent this blood. Yeah.
Okay. And before that, when was your last thyroid function test done prior to pregnancy? Just want to know.
I think 3 months ago.
3 months ago. And they were normal, right?
I can't remember. Maybe the GP would
Okay.
provide you that
Okay.
information.
Okay. Fine. It's okay. So tell me more about your periods. Like prior to pregnancy, were they regular?
Yeah, never had any issues with the periods.
Okay. And are you up to date with your cervical screening?
Yes.
And they're normal, right?
Yeah. All normal. Yeah. No issues
Okay,
whatsoever.
okay. Any me other medical condition for which you are under GP follow-up on regular basis?
Not that I know. No, not that I'm aware of.
Any family history of concern you want to share with me?
The only thing I would know about is my mom had a blood clot in the right leg, as far as I
Okay,
remember. Yeah.
okay, okay. So, when was she diagnosed with this problem? At what
Um,
age?
it was in her 40s, and
Okay,
it was not related to any
okay.
condition or anything.
Any condition. Okay. Definitely, I will be noting this down in my case notes. So, any surgery on your tummy or down below?
No surgeries, no.
Okay. Do you drink and smoke alcohol? Do you smoke or drink alcohol?
Occasionally, yeah.
Occasionally. So, Annie, I just want to tell you that it is basically suggested that smoking and drinking alcohol, they are not usually considered safe in this pregnancy. Okay. It can harm your baby and you as well. So, I will be suggesting you to cut it down if possible. Okay.
Okay.
For that, I
Yes,
will be connecting you with the support groups as well and it's just stop smoking services. Okay. If
yes.
you want.
Thank you. Yeah.
Apart from this, any history of recreational drugs as well?
No, no, not recreational
Okay. So
drugs.
do you know about your weight height ratio?
Yes, my GP measured that, and I think it's 32.
32. Okay. I will be noting this down because it will be altering your management during pregnancy. We need to increase the care accordingly. Okay.
Thank
And
you.
what about your blood group?
I am B positive.
B positive. Okay. So what do you do for your living?
I'm a teacher.
Okay. And how's the support at home?
All good, yeah.
All good. Okay. So any drug allergy?
Yes, I'm actually allergic to aspirin.
Allergic to aspirin. Okay. So this is also worth noting for your case. And how had you been feeling in the past few months? Everything is going fine?
Everything okay, except as I told you, I'm just very concerned about this problem and how it can affect pregnancy.
Okay. Don't worry, we will be connecting you with counselor as well. Okay. So thank you for sharing all this information. You can see till date, pregnancy looks fine only, and I would like to congratulate you for this. Okay. And I would like to examine you in the presence of chaperone. Will that be fine?
Yeah, yeah, that should be okay.
Okay.
But
So,
doctor, can I just understand how will this condition, what is this condition and how will it impact my pregnancy? I'm just very anxious in view of my history, yeah?
yes,
Mm.
I'm just going to discuss about that only in a
Mhm,
while.
mhm.
Okay. So, do you want somebody to accompany you for this discussion?
No, I'm okay. I'm okay at the moment.
Okay. And has anybody else discussed about your reports prior to this appointment with you?
No, no, that's why I'm very worried. Yeah.
Okay. So as far as I can see, your almost booking results are almost within normal limit. Okay, the blood tests which were done for you, your thyroid level, TSH, which what we call in medical language, it's a bit raised according to the
Mhm, mhm.
if we compare to the normal pregnancy range. Okay. So basically, don't worry. The team of doctors will be taking care of you, good care, which will include my consultant and
So what does
special.
that mean? That blood test raised? What does it mean? What condition is it?
It's in medical term we call it as hypothyroidism, basically. Okay.
Okay, okay. Mhm.
Okay, so in that condition, usually the thyroid hormone levels is deficient in the body, and it causes reflex raise in this hormone level. That what TSH report is given for you. Okay.
Okay,
It could be physiological as well, but the range which you got in your report is not in that physiological range. Okay. We must need to evaluate you further to see the causes. Okay.
okay,
And see whether it is not affecting your baby as well.
okay.
So, Okay, don't worry, we'll be taking good care of you. Our consultant, specialist doctor, specialist nurse, and the sleep doctor, everything, everyone will be involved in your care. Okay,
Mm-hmm. And so,
so
what exactly are the steps that we are going to take to prevent this condition to affect my baby?
yeah, if everything is
Another,
controlled,
just to give a heads up, the time is up, but I still want you to complete the station so that I can see that if it would have been within 10 minutes, what would you
Yeah.
have spoken? Okay, go ahead.
okay,
The time
Mhm.
is up, please. Go ahead.
okay, sorry, ma'am. Regarding your condition, if everything is controlled in pregnancy, like hormone levels are normal, then we can expect a good outcome in your pregnancy. And if it is uncontrolled, then it do affect you as well as your baby. Okay. So in your case, there is increased risk of conditions like delivery prior to the due date, and sometimes it is associated with increased BP records and urine in the protein. Okay. And if for your baby, it can be like abnormal thyroid levels in your baby after birth. Okay. And we can expect loss of pregnancy in early time of pregnancy as well. Okay. So don't worry.
Will my baby be growing okay?
Yeah,
Will it develop okay?
this condition, it is basically seen in many patients that the growth of the baby is usually not affected much. But
Mhm.
if the value is very uncontrolled, then it might affect the baby as well,
Okay. And
growth as
how
well.
often will you have to bring me to the clinic and monitor my
Yes.
bloods then?
Yes,
Mm.
yes, I will be explaining you. So your
Mm-hmm.
care will be a consultant-led care where we'll call you on regular basis, like 4 to 6 weekly, according to the pregnancy duration, and we'll
Mm-hmm.
advise you to regular visit with us. We will be assessing you for the risk of clot formation in your legs as well and lungs, as you had a history of positive history of your mother getting clots in the legs, and your BMI is also in slightly higher range. Okay. Apart from this, I will advise you to continue this folic acid, and will advise you vitamins levels,
Is it
vitamin.
a regular dose, doctor, that I'm taking the folic acid?
Yeah, you need to continue that only.
A regular dose, yeah? Okay.
Yes,
Mm.
and we'll give you vitamin D tablets also. Okay. Apart from this, I will be connecting you with the sleep doctors in the later half of pregnancy to assess your wellness. Okay. And we will be conducting your blood test. Like after this booking test, we will be advising you Down syndrome screening at 14 weeks of pregnancy. And
Okay.
after that, 12 weeks of pregnancy, and after that, detailed anomaly scan will be done. Detailed scan of the baby is done at 5th month of pregnancy.
Okay.
Okay. And after,
And doctor, can I ask you one more thing? I would like to have a delivery with the midwife as natural as possible. You know, I'm a bit afraid of the hospitals because of these situations before that I've experienced with miscarriages. Would that be
oh,
possible with this condition?
definitely, we will be discussing this in as the pregnancy progresses. We need to see your parameters and your blood test report as well. If everything is controlled, and then we can plan a midwife delivery according to your wishes. Okay. So we will be doing your thyroid function test every monthly, almost like every 4 weekly. We'll be testing you. We'll do your antibodies levels also to thyroid at around 6 months of pregnancy to see with the risk of your baby being affected or not.
Right.
Okay.
Now
Okay.
I wind up the station, my dear. Last 1 minute.
Okay. So for your delivery, we'll be taking consultant-led care only, and we'll give you pain relief. Okay. And if your levels are deranged at that time also, then we might need to do continuous monitoring of your baby's heart. Okay. And we'll give you medicines to decrease the blood loss after birth. And after the birth of the baby, I will be like we will encourage you to breastfeed your baby. We'll get you connected with a specialist doctor as well for medicine, dose alteration if required. Okay, the baby doctor as well will see the baby and check whether the baby will require the tests and blood medicines for thyroid problem if any. We will be giving you suitable contraceptive advice as well. Apart from this, we will be writing a detailed summary of in your discharge, and will advise you regular follow-up with us. Okay. So as of now, coming to your current day, I will be booking a Down syndrome screening for you and booking a consultant appointment and a specialist doctor appointment for you. Okay. And so that we can alter the dose of your medicine, which you are already taking. According to this value, we need to alter them. So these are the patient information leaflet, and will get you connected with the support groups as well and counselor as well. Okay.
Yeah. Thank you, doctor.
And dietitian as well. Okay. Anything else you want me to take care for you?
No, I think that's it. Yeah. Thank you.
Okay. Thank you so much.
Thank you very much, Maninder. It takes a lot of courage to face the audience at the very outset. I would like to really appreciate, because if I would have been at your place, I would have been super conscious to see like so many people are listening to me. But thank you very much, and hats off to the confidence which you have presented. Very well done. Let's ask the role player before the mentor that what were those points which made you comfortable, and what were those points which you think that as a role player only that could have been better in the doctor.
I think overall the communication with the patient was good,
Okay.
and overall there were a few safety points. I think
Mm-hmm.
the communication I think you were overall reassuring
Mm-hmm.
towards the patient. I think you had a tone that was calm and comforting, and that those were very good points from my side. And I felt like I was, from the patient's perspective, I felt like I was listened to, and you did acknowledge, my
Right.
requests, yeah, and my
Mhm.
concerns, yeah.
Thank you very much. Would you like to see this doctor again?
Mm.
Are you coming for the next antenatal with the same doctor? Is it? Yeah.
Yes, definitely, yeah,
Thank
yeah,
you
yeah.
so much.
Thank
Thank you
you
for
so much.
your help. I'm always grateful, sweetheart. Thank you so much. Thank you.
Thank you,
All
yeah, yeah.
right. So, how was the presentation, Maninder? How did it feel? I mean, you knew the topic, but of course you didn't know that it's hypo or hyper. But today the topic was known that it's thyroid. When you saw, what did you feel that would you be able to do that, and what were your apprehensions before starting?
Ma'am, actually, truly speaking, I prepared for hyperthyroidism, a
Oh,
Graves'
I
disease. I
see.
listened to the your pre or recorded audio guide
Graves'
from the
disease,
thyroid.
yeah?
Yes, ma'am.
Okay.
So, but in that also you guided us like you can follow the general template for maternal medicine in almost
Mhm.
every cases.
Mhm.
Just a specific points like patient safety point we need to add on.
Yeah.
So I followed you in that also. So I
Right.
followed the general template which you guided us for maternal medicine, ma'am. And
Thank you.
apart from this, I missed this applied clinical knowledge part due to time constraints.
So, if I would have been at your place, I would have just started and I would have seen that it's a maternal medicine. The only thing in my mind as a candidate would have been time management. All of
Yes,
you,
ma'am.
please listen to me very carefully. Maternal medicine are the longest stations. Maternal medicine are those stations which I have been teaching for years and years and telling that the only stations where you people would have difficulty in shrinking the history and completing the stations are maternal medicine stations. So, if I am a candidate, I am outside the cubicle and I am seeing a maternal medicine station, I will be telling myself that first 3 4 minutes are very crucial where I need to wind up my history. Akansha, are you there? Fatima Ali, hi Tim. Yes. When we talk about the maternal medicine, guys, we talk about the time management, because why I gave Maninder another 3 4 minutes, because I wanted to hear she knows that, and exactly she knew the things, she knew the recommendations, but in exam I am not able to mark those things because it's after the bell. And of course, you guys know that when your 10 minutes are over, automatically your next 2 minutes they start. You guys know that,
Yes.
right? So you have to stop no matter you're in the middle of telling the diagnosis or you're in the middle of telling the condition. Wherever you are, you have to put a full stop there. Nobody's going to give you an extra time because your next 2 minutes reading for the next station automatically starts. Am I clear? So the first take home message is time management. Now we will go step by step with the domains and see what exactly was the information which I wanted and how I took the feedback side by side. This was an exam station with a role player with 2 miscarriages earlier. She was on thyroxine already and she was 8 to 9 weeks. She was allergic to aspirin with a BMI of 32. Many
Mm.
things were asked and I was very happy on the history. However, I was just seeing that history was expanded a little more. If I would
Mm.
have been at the participant's place, I would have tried to reduce the history, keeping in mind that my applied clinical knowledge or the information giving part is equally important and that's too lengthy, right?
Mm.
In the exam, ladies and gentlemen,
Okay.
she had these questions: how it affects my pregnancy, how do I do a follow-up, can I have a delivery with my midwife, will it affect my baby? And I have a prompt here. If you see, 3 times the role player did try to ask a concern, but the answer she got was, I will get back. And one time I've written, give me 5 to 10 minutes. And I was like, you don't have this much time in exam, you know. Immediately the participant said that I have, please give me 5 to 10 minutes, I'll come back to it. I immediately wrote it down that you can say I'll get to it in a bit, but 5 to 10 minutes is too much and we don't have this much time. It just like happened spontaneously. Am I right? Yes, Cor. Yeah.
Mhm.
Now, in this situation, you have to acknowledge, but what is the key to take a focused history is in front of you, and I'm going to make you memorize that. Before
Mhm.
I begin, I would like to give the feedback what I've written and their e-notebook. I've got some pink points which I really want to discuss with you. The first and the best thing about Kaur was that when she started, it was that she said, I'm one of the doctors in the high risk assessment unit today. So that was really good. She had a very good situational awareness where she communicated with the name. Agenda was okay, but I would like to appreciate if you go back to the recording and listen to it again. The agenda was made that you're here in your third pregnancy and you've got 2 pregnancy losses. Is that fine?
Mhm.
Rephrase that. I've written that. Rephrase that by saying, am I right?
Okay.
Because you have to confirm that why she is here. What is agenda, friends? Agenda is that what is the reason the patient is meeting you today? Do you guys understand, everybody, what is agenda? Yes, Fatima Ali, Haitham, please, everyone. You guys understand what agenda means? This is the confirmation of the reason for which the patient has come to you. So you say, you speak that why she's here. Am I right? Rather than saying, is that fine? Let's just rephrase that, my love. Then I was very happy in communication with the patient when there was a nodding and okay and acknowledgement. And I think the role player appreciated that as well. Whatever she was saying, it was being acknowledged, and this nodding gives you score. Remember that. If I was at the participant's place, I would have addressed the concerns there and then to get the score in my patient's safety. I have written here at around 3.54 minutes, role player analyzing the time said, can you please tell me what is in my reports? And the answer given was, I will get back to it, a few more minutes for the question. Now, all of you tell me that do you guys have an understanding that she told in the beginning, Pooja, that I am on thyroxine, correct? So,
Yes, ma'am.
don't you think that she's
Yes.
already knowing that what the condition she has?
Mhm.
Correct? So,
Yes, ma'am.
I would have taken that opportunity to say, as you have already been evaluated and as you are taking this medication, same has been in the report, the thyroid levels are deranged and it is reduced levels of the thyroid hormone. We call it as hypothyroidism. Can I ask few more questions and then we can come to the management plan? You know
Okay,
why?
ma'am.
You know why? Keeping in mind that it's maternal medicine, I might not get chance to come to it. And the moment you guys will address the concern, immediately the examiner would be concern addressed.
Mm.
And when the participant did not address the concern, and me sitting on the examiner's side, I have marked it blank,
Mm.
waiting that maybe she comes to it. There is a chance that we don't get an opportunity. Are you guys with me? Anjali, Madhabi, Andali, my dear. Yes, all of you. Namdi, did you guys understand that? Yes?
Yes.
So,
Yes.
get the point in the shortest possible time there. I don't want you to expand, my dear. I don't want that you start explaining the management. Get back to the history. But immediately do that there so that it saves you and touch the scorecard. Because
Oh,
whatever role player is saying, friends, is doing on purpose, is doing to because she was understanding that the time is being used so much for this, right? Then in information gathering, I have a concern. Listen to the recording. Around every 1 minute, we were saying okay at the end of every sentence. Now, it is not something which would be a failing point. Let me be very transparent, but there is a point that it's not pleasant to the ears if something is being heard again and again. So 4 to 5 lines, please open up your notebooks. 4 to 5 lines you guys can write to make a change in the acknowledgement and, checking understanding. When the participant had to check the understanding in the every end of each line, she was saying, okay. So that means that it's every second line we are saying okay. So we can rephrase that like, different lines to check understanding. Is that fine for you? Is that okay for you? Are you with me? Are you following me? Am I clear so far? And then these 5 you can, change again and again. So every second, third time when you want to check, you have 5 to 6 sentences different rather than one sentence and speaking again and again, because then it looks a little, repetition. Smart candidates and the beautiful presentation skill is that you are pleasant to ears and you're touching the scorecard. This is the gist of exam and presentation, right? Thank you very much, Rosina, for loving it. So write down 5 to 6 sentences, learn them by heart, and you can, change them up and down, and you can just make them again and again. Rather than repeating one, you can just do it up and down. Noted, please. I have noted this when there was the presentation going on that how to make it more beautiful. Now let's come to information gathering. I was very happy with information gathering regarding the pregnancy, asked about the initial symptoms, regarding the thyroid symptoms. I was happy when the folic acid was asked. I was very happy on my role player doing a prompt. But what was the answer which we got on the folic acid? Anyone? Thank you very much for the purple hearts, and Panda. Love you so much. What was the answer? Did somebody notice?
GP has
Yes,
the
I
GP has
do.
started.
Yes, GP has done what, Akansha? Come on.
The GP has started me on folic acid.
How much was that?
She told about the normal dose. She's told about
She said the regular dose.
the regular dose. Yeah.
And
BMI high.
did we have to do anything? She
Yeah,
did ask.
Yeah, 5
BMI.
mg obesity.
She gave a prompt, and the participant said, "No, it's okay to take regular." Why?
I missed that part, sorry.
What was the missing part? Tell me, please.
Ma'am, her BMI is high,
BMI.
so
Thank
to
you
give
so much. I really love the reinforcement. I'm super proud of you. Well done. So, mistake which we are making today, we have to learn that 90% of the pregnancy cases, you will be checked on high BMI and high dose folic acid, changing and shifting so that you don't forget. This is where MRCOG 3 exam tests you. 90%. Please open up your notebooks, guys. 90% of the pregnancy cases would be shifting from 400 microgram to 5 milligram, either diabetes diagnosed now or obesity, epilepsy, sickle cell disease, thalassemia, neural tube defects, previous anencephaly, all these would be coming up. So here, the idea about 32 BMI was that please, and if you see, this happens in exam, the role player tries to help you because it's highlighted in front of the role player, but sometimes we just have some sort of a mental block. She asked 2 times, right? And she said, okay, regular dose. Okay. I mean, she was like, please think about it, but she couldn't help more than that, right? So she was trying to help you that it's 5 milligram. But the problem is that immediately when this happens, the patient's safety goes immediately from passing to borderline. Another mistake you guys do, it goes to failing. And then if you gain up more, if it's not at an static point, then you have to put an effort to go back to passing. Do you understand? Immediately as an examiner, I dipped into the borderline there because that was a big mistake because of higher BMI and giving her, she is 8 weeks and knowing that she has previous losses as well. So this is a very precious pregnancy. Am I right?
Ma'am, she's asked me in this applied clinical knowledge also at that time when I was discussing. She asked me again about the folic acid dose. I missed that.
Yeah. So probably when overlapping things like 2 conditions they come up, so we tend to lose the, the focus over that because probably you were all together into the thyroid. Am I right? So you just missed the obesity part. So remember, obesity alone is also an exam station, but obesity with asthma is an exam station. Obesity with hypothyroidism is an exam station. Obesity is merged with those maternal medicine disorders where the applied clinical knowledge is scanty and less. So, to make a data in the station. All of you, please. This is how the obesity is merged with other maternal medicine. Coming back to the information gathering, I've written the family history of blood clot, noted that was very good. By that time, 6 minutes were done. Surgical history was asked. Smoking was occasional, so you don't need to do smoking cessation. Any patient who is having occasional, you can tell about that harmful effects in the pregnancy, but you may ignore if it's only occasional. All right, okay. So vitamin D, you did ask. Vitamin D would also be higher dose. Am I right, everybody? Shivangi, BMI 32, my love. Yes, vitamin D obesity is also higher dose. You can mention in the patient safety. In patient safety, you mentioned the specialist doctor. I was very happy. Thyroxine, I was very happy. However, all these things were unfortunately after 10 minutes when I gave you extra time. So if I be strict, and let me be strict so that you guys don't make this mistake, I would pass in the information gathering, but I would be very honest, because of this information gathering being 8 minutes, patient safety and applied clinical knowledge is failed. If I take 10 minutes station, you know, what is the reason, Aruj? Because of information gathering, expanding it so much, we took the time which had to be for the information giving part and the patient safety part. Do you guys understand? Right? So if I take it as a 13 minutes or a 14-minute station, then I do appreciate that your knowledge was appropriate, my dear. Despite still, in 14-minute station, still the patient safety I would not pass. I've told you the reasons for that, right? Even in 14, it was a mistake. But at least the applied clinical knowledge, beautifully you told about 4 to 6 weeks. I'm very happy in the way you came to the baby effects and the postpartum care. I was very happy the way you continued. Now, one suggestion from my side to all of you is that to reduce the time, avoid asking the questions that's already been there. For example, you did ask about the blood group, correct? If I
Yes,
was
ma'am.
at your place, I would have already noted it down with me.
I've noted, ma'am. Then I
That's
forgot.
That's
I've
the
noted
reason,
it.
Gaur. Gaur, that's the reason. You know what happens? That if you're not able to do filter, see,
Mm.
I am a candidate, Fatima. Sornalata, listen to me, my love. I'm a candidate and I have my maternal medicine template in my mind. Akansha, we have to understand that what to ignore, which is already given. This is what we are not able to do. We say no, A to Z, we have to ask everything because we have a template in mind. And when you are doing this, then why in the world college is providing you certain information? This is only to make your time management. See, the things are with me, and if I'm asking them again, definitely yes, I am utilizing more time, and the information that's been given to me, that is going to utilize my time for the information giving part at the later part of the station. Yes or no?
Yes, ma'am.
Yes, Haitham, Andalib, Anjali, my love, Madhabi, everyone, please be active in the chat box so that I can see you guys. And if Rosina, thank you very much. My my point here is learning the template and history priya is the first step. Learn that. Without that, we cannot be fluent in history. But then please learn to filter. When you do with your study buddies, do it in a way that you guys exactly know this is to be spoken, this is not to be spoken. This is something which I will ignore. For example, in the same case, if I write down she doesn't smoke and she doesn't drink alcohol, you should be having a presence of mind to say that I've already been informed about your personal habits. I appreciate that. See? This is how I would acknowledge and show my situational awareness to my examiner. Understood, everybody? This is how I'm going to take it further. Thank you very much, Zarifa. A few more days and you guys would be in part 3. I'm waiting for you guys. Did you guys understand? Now, I've written few lines just to rephrase, which I would have done a little better. In the beginning, it was 30 seconds to be taken like consultant is not here. Don't take too much time. Right, Cor? You took too much time to tell that my consultant is not here. He has informed me about everything. If I would have been at your place, I would have just said that at the very outset. I would like to tell you that my consultant is away because of some unavoidable circumstances. I'm here to take forward the consultation. Is that okay for you? That's it. You don't have to get into too much of a thing and take it expand so much that your rest of the station gets affected. Got it, my dear? This is what you should know. The main tip to pass maternal medicine, remember, is the time management, right? Is the time management. You should know that it can have effect on the development of the baby. It can have up and down in the thyroid concentrations. The doses have to be increased. The symptoms can worsen and it can affect the outcome. I have all the ways to make you learn. Please remember management. Take my words today, guys. November 2025, 100% we are getting management of thyroid disorders in pregnancy. The Green Top Guideline number 76. You have to learn this GTG. All these recommendations should be on your tips. We did today this part specially that the TS set should be 2.5 and less, and we had given around 15 in the station. It should be known that how frequent it has to be checked, 4 to 6 weeks according to the gestation, and then again at 28 weeks it would be checked till 20 weeks. This is the most important new recommendation and new update which is there. You all should be able to speak that because this would be part of the aesthetic point in the key, and this is comparatively easier than that of hyperthyroidism, where lots of propyl thyroxine in discussions, and they hear the treatment of choice is thyroxine only. All right. So you should be knowing about this. You should be knowing about that difference between the subclinical and the overt hypothyroidism. Open question, please. Who's going to answer? And how would we understand that she is having subclinical or overt hypothyroidism in exam? Because the effect on the pregnancy varies, please. Open question, please. Anyone?
On the free T4 levels, ma'am, if they are normal with a deranged TSH, then it's subclinical. However, if the T4 is raised and reduced and the TSH is high, then it's overt hypothyroidism.
What about the symptoms?
So the symptoms in overt hypothyroidism will be there, and in subclinical, it won't be there. Only TSH will be raised more than 10.
Thank you very much. This patient is apparently fine. However, remember that subclinical hypothyroidism is only TSH picked up. So in the station, she was already on thyroxine. So basically, we assume that it's an overt. She didn't have the symptoms. However, T4 was not given in the station. Am I right? Yes,
Yes.
but because she was already there, so we expected that this patient, because the previous 2 losses are also there, right? So she was already a diagnosed case. But otherwise, you should be knowing that T4 should be with you, because that is the only way. If the patient is asymptomatic and she has losses, that's the only way to differentiate between overt and subclinical. Am I clear about this? Yes?
Yes.
With all this, you have to learn the way to organize your thoughts in SPT. SPT doesn't mean that you actually don't know the station. You all know that. The problem happens when you guys know it, but lots of things coming up in mind. You know, thoughts are so much, and the coherence with the tongue and the neurons, that is not happening. Sometimes so many thoughts coming up, like for example, I'm sure that now if Core gives a second thought to 5 to 10 minutes, you would be like, why did I speak that? Why did I say give me 5 to 10 minutes? But it happened. It happened because we are under the pressure of exam. And this is what happens in exam, right? Learn organizing your thoughts. Whenever it's a maternal medicine, do the HOPI. Pregnancy symptoms, thyroid symptoms. Thyroid symptoms, the symptoms, cold and heat tolerance, and did she visit her thyroid specialist? Learn organizing like tick, 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 connectivity. HOPI done, she's a pregnant patient, OBS history. This was the time where you could have gained communication with the patient score, Maninder, and you missed it. It was a point, if I was a candidate and I was standing 2 minutes outside the cubicle, immediately Shazataha, I would think that she has losses, so I have to be empathetic in that case. How? That when I take the OBS history, I'm sorry taking you back to the difficult memories. I'm sorry for your early losses. Can you tell me the details about that? Right? Now, she told earlier, you could have said that, I'm sorry to hear about this. We are here to support you in this situation. So basically, losses either pregnancies or family members, they give you an empathy score. Okay, always it should click outside. Okay, this is here, I'm going to get score for my empathy, right? You can offer support, you can offer counselor. Make sense? Okay. Gynec history, especially when it comes to thyroid, the period's details are important, and especially when she's into the early pregnancy, 6, 7, 8 weeks, because they have irregularity. So it's very important to have the dating scan in these patients. It's another point. May that be regular periods without any, this type of a disorder, menstrual disorder, it would be fine. But especially in thyroid cases, the menstrual history is important because that does make it right. Okay, that's enough, Ala. Absolutely. I'm sorry for your loss. We can connect you to the counselor. We are here to support. That's it. So that gives you a score, Ala, my love. Okay. Medical, family, surgical, personal history was okay. She did ask about this. BMI, Zainab Iftikhar Shore, my dear. BMI and allergy. This session is going to be uploaded on YouTube, sweetie. You don't have to worry. Everything is going to be uploaded, okay? Right? Then BMI and allergy is something which is very important. Jehovah's, you should rule out, because often the patients who expect, like surgical patients or post-operative, one patient in your exam out of 14 is always Jehovah's positive, right? They have the positive history for that. BMI was mentioned. However, the effects on the BMI we missed out, like folic acid. You did mention the VT thing. That was amazing. Very well done. You did say that we are going to assess you, but somehow the folic acid thing missed mentioning, my dear. Now, the mental health history is important otherwise, but here it was more important because in the beginning she says, I'm very anxious because I had losses. And this is a third pregnancy after 2 losses. Any mother at this point in time would need some extra support. So I was expecting that these all points should already be with you in 2 minutes time. That I'm expecting this because it was written in the candidate instruction. She's very anxious today after 2 losses. Yes or no?
Yes, ma'am.
Got it, everyone? Now, once you enter from your introduction, everybody, from the start of your introduction, your attire, how you're entering, head to toe, how you look, your communication with the patient has started being marked with the examiner. With your hello, we have started marking you, right? You should be able to inform the patient without jargons and the effects on the mother and the baby in a very, very small amount of time when focused towards an easy language and checking understanding. Please make sure that you make 4 to 5 statements to check understanding so that it's not that you're repeating one again and again, because this gives communication with the patient. You're nodding, your eye contact, your sitting posture, your choice of words, your empathy when you're telling about some news and you're bending forward. All this is empathy. When you are offering support, when you're giving information in a very simple choice of words, this is all your communication with the patient. Please avoid jargons. Thank you very much, Reena. Miss you more, my love. Please avoid jargons. I'm happy I didn't see any one of it. I'm very glad, Cor, that this part was very strong. And I'm happy that you had a good grip over making a plain language at that point. Now, you should know that as an examiner, we are always looking at patient safety where we missed, and the reason for which I failed the patient safety for the participant was effects on the BMI. Aspirin allergy was documented. That was amazing. Jehovah's was not checked, but because my patient was not Jehovah's positive, so it's okay. We had an escape, but in exam, she might be positive, right? You have to tell the pregnant patient always, can I have your all notebooks in front of you guys? In a pregnant patient, you are giving LMWH, you are giving aspirin, you are giving thyroxine, you are giving propylthiouracil. Any medication you're giving, it is a patient safety to tell that it is safe to give this medication both for the pregnancy and for the baby latching as well. Is that okay for you? This is the basic information that is expected by the patient and as a maternity team doctor. Do you guys understand this? Never miss it. Shazil, are you there? Shazil, when SPT is there and when pregnant patient is there, you have to mention about the safety of the drugs. And similarly, there are stations in exam where we have enalapril and we have to shift the patient to the safe medication. Thank you, my love. I can see you. Thank you. So you should be knowing that we have to tell about this. So mentioning in one line core that thyroxine is considered to be safe medication both for the pregnancy and for the breastfeeding. Yeah. However, we have to adjust the dose in the pregnancy if that's okay for you. Right? This was the part where we missed out because it was a merged station of hypothyroidism with obesity. Let me remind you guys again, make one stick on for the obesity effects. For example, folic acid raised, vitamin D raised, VT, risk assessment and giving low molecular weight heparin, more chances of infection, more chances of cesarean section, right? Macrosomic baby or fetal growth restriction, GDM, PIH, preeclampsia, all these things, write down on one stick on and please paste it in your maternal medicine first page. Why? It can be an alone station or it can be any maternal medicine with obesity. So if it will be on your tips, you can immediately enumerate. But if it will not be in your head, then definitely you would be taking time to, recall, oh, this can happen, this can happen, this can happen. As I'm telling you once again, I have a recall with asthma and obesity, right? I have another recall with Charcot-Marie tooth disease with obesity. Whenever the maternal medicine is very scanty, they just merge BMI 32. So you have to, put in those things with that because they have to make a 10-minute station as a time. Understood, everybody? Are you guys with me? Shaza, but she didn't need actually, yeah, as a prevention. You're telling about because she's not a primary gravida in obesity? Shaza, my love. Okay, my question, is she a candidate of aspirin, ladies and gentlemen? An open question. Yes or no? Is she a candidate of aspirin? If yes, why?
No, she is allergy. She has
No,
allergy.
No risk factor.
Otherwise for prevention. What risk factors are there?
Primary gravida.
She was
BMI more
not
than
a primary
35 is a
gravida.
risk factor.
She was not a primary gravida. That's my point. Was she a primary gravida? No, she had 2 miscarriages earlier.
High BMI.
High BMI soul is an indication of aspirin? Who says
No,
that?
no. No, madam.
Two of the factors should be present of intermediate risk
Very
Two
well
factors.
might,
done,
two
Suvan.
moderate and one
Super
high
proud
risk.
of you. So she would have been a candidate of aspirin if she was a primary gravida with obesity. Right? And BMI is not 30, 35. BMI is the cutoff for hypertension, guys, not 30. So she was 32.
35.
Shazil, she was not antiphospholipid antibody, my love. Shazil says, friends, that she had 2 miscarriages. I understand. But does that advocate that she would have aspirin? Aspirin and low molecular weight heparin are given for APLA, right? Antiphospholipid antibody. Was she a candidate? No.
What about autoimmune disorder as taking
If
thyroid
she
disease?
would have, yes, then she would have been a candidate, Zoya, but she wasn't. She wasn't
Okay.
having autoimmune. She was
Okay.
known to be having a hypo, right?
Okay.
Shamsa says in a different scenario, if the patient is a candidate, yes, absolutely. Then we have to do an MTT and the specialist has to decide just risk versus benefit has to be taken, my love. Okay, then it has to be a consultant decision weighing that what is suitable for her, my dear. Absolutely, Ruth. Vinu says she
Dr.
had been
Sadhguru,
worked up and she said only. Exactly, Vinu, my dear. Yes, Zoya.
if
Ma'am, she
she has
said actually,
antibodies
she
like
said she's
thyroid,
been worked up for repeat miscarriages, and she has been found out that she has only hypothyroid. She said
Exactly.
in
So then we don't need, right? Yes. Thank you very much. No, Shazil, here in MRCOG3, it has to be antiphospholipid antibody positive. It is not indicated for any patient to have aspirin. Okay. All right. So Aparna, we would do that if at all we don't have a diagnosis. But if she's already a diagnosed, my love, then it's not needed. Okay. Yes. And that too, Shazil, when she is diagnosed in Ireland. Yes. In Ireland also, when we have a diagnosis, my dear. Now, after being organized in information gathering, after being organized and hitting the patient's safety, you should know the applied clinical knowledge. Always in maternal medicine, think about 2 directions. Effect on the baby. Yes, she can have a premature birth, low birth weight, and impaired development of the baby, right? and effect on the mother, it can be an adverse outcomes and the pregnancy loss, right? Remember that as any maternal medicine, you should be able to tell that safe range of the lab values. We have to reach out to that, and we have to adjust the dose of the thyroxine. In the pregnancy, it might be increased because of the requirement, and after the birth, we are going to reduce it back to the value before pregnancy. We are going to check with the thyroid specialist, take her through the antenatal, intrapartum, and postpartum care. Nothing is extra in the intrapartum, same routine, same postpartum. However, in antenatal, only 2 points are there. Because it was a scanty maternal medicine and obstetrics, therefore, in exam, it was merged with obesity. Do you guys understand that? Right? So the basic applied clinical knowledge was very less. It was doable. It was doable in 10 minutes time. I would like to take questions before I do the do's and the don'ts with you guys of a simulated patient task. Please, any question in the station, any line which you want me to utter that you're not able to describe that for the patient, you're not able to explain that to the patient, or if anything's in a simulated patient task, if any question is there, please let me know. Yes. Yes,
Dr.
Zoe.
Sidra,
Yes,
will
my
it be she asked for midwife delivery, right? If it's a controlled hypothyroidism, no
Yeah.
other risk factors, baby's growth is fine. Can it be a midwife delivery, or because it is a medical condition, it has to be a consultant led?
No, as per the NICE guideline, a
Yeah.
controlled without complication can be a midwifery, but I would not say that at 6 weeks. You
Okay.
know, you ask me, for example, you're the patient. What would you like to ask me? Ask me that question. I would like to answer that. Yeah.
So if I would just like to know that if I can deliver at home with a midwife in this condition, if my labs are controlled by the time of delivery.
All right. So, Anne, I do understand that you're quite anxious at the moment, and we would support you in your choice. However, it's very early to comment upon the time of the birth. Mode of the birth does depend upon the circumstances at that point. If everything would be straightforward, we would look into your choice and support that. However, we'll monitor the pregnancy and see around 36 weeks and discuss all the options available with you, if that's okay.
Okay.
Okay. I would not give a word that yes, it can happen because I don't know what complications can happen. But you as a
Yeah.
patient already said that, if everything is fine, that means you're already aware.
Yeah.
So you're a good
Yeah.
patient. But in exam, it
Yeah.
doesn't happen. In exam, she says,
Yeah.
I want to have a midwifery birth. So
Yeah.
then you have to say that, keeping in view that how the pregnancy goes, we are going to look forward to support your choice. However, it depends at 36 weeks that how the pregnancy is, how the investigations are, how the baby growth is, and we will be discussing all the options available around 36 weeks with you.
Thank you.
Most welcome. Sadia Mustafa, yes, please.
Hi, ma'am. How are you?
I'm good. So good to see you, my dear. It's always a pleasure seeing your name, my love.
Thank you.
Yes, please.
Thank you so much. I just want to comment on this question actually that as per the recommendations, any pregnancy who's got any medical disorder, unknown medical disorder, it is a high risk pregnancy and has to be dealt with a multidisciplinary team. So I think it should be in the consultant-led unit.
Okay,
As
so
per
Sadia, see the NICE guideline? NICE
yeah.
guideline. And there's a table there, right? And in that table, they have mentioned that hyperthyroidism is always going to be in the consultant-led unit. Only low-risk hypothyroidism, no complication, the treatment required stable patients can be considered. However, keeping in view that she's only 6 weeks, so then we should not be commenting upon. So take time and tell her that approaching towards the end of the pregnancy, we'll be in a better position to tell you. This is the best answer.
Okay.
Ma'am.
Okay.
Got it.
Thank you very much, my dear. Thank you very
Ma'am.
much, Anuba. Oh my God. Anuba says you are oxygen, ma'am. I miss you guys so much. Thank you so much for joining in, my love. Yes, please. I'm here for the question.
Yes, ma'am. Can I ask one question?
Yes, Anjali,
Yes.
please.
Ma'am, in this case, what is the role of low molecular weight parent? Should we start from 28 weeks because her age is 36 and BMI is 32 and her family history is 1, mother is having clot. So 1 score for that. The total score is 3.
So family history in mother, in the VT pregnancy score, it doesn't give until unless we have some reason for that or thrombophilias for that. Okay. Another important thing is that here, in this case, the best thing to speak because of scanty information, we are going to assess you for the blood thinners. This is the best thing. And the block will get tick, my dear. We will assess you for the blood thinners in the pregnancy and after the birth of the baby. That's the best thing to speak. Because exact scoring needs complete evaluation of everything, right? Assessment is the
Okay.
best thing. And do that and you'll be safe in the patient's safety. Okay? Thank you very much. Yes, Aparna, my dear, you're saying something.
Ma'am, there are two things. One, in this case, she's already a hypothyroid and also an obese. So most likely with the two combinations, she may not be a lady who can be delivered at midwife care.
No,
That is one
obesity,
point.
absolutely. So we were talking about the thyroid as a reason. Obesity definitely adds on, but if I take obesity alone also, so keeping in view that type 1 obesity can be with the midwifery. However, we'll take her as a primary because she doesn't have previous delivery. So then it's a very tricky thing. As I told you guys, never say yes, you can go, no, you cannot go. So it's very early to comment upon that. This is going to depend upon how the pregnancy proceeds further. This is the best answer and this is the safest answer to go ahead with that because at 6 weeks, we cannot comment upon that, right?
And my one more point is that are we supposed to tell as to how much of a dose she has to be increasing her thyroxine because she was already on 100 and now her TSH is elevated? Or
So
should we be telling her that
if you remember, the role player, she asked the role player that did you meet your thyroid doctor? She said no, only GP. So your patient safety is that as early as possible, please connect her to the
what
thyroid
for her
doctor.
too? Right,
Yeah,
right.
absolutely.
Thank you.
Thank you very much. Thank you. Any other question? Anything which you guys didn't understand, anything you want me to repeat? If you want, I can do the whole station so that it stays in the recording and you can listen to it and then we can go to the do's and the don'ts. Are you guys okay with the lines which I gave in bits and pieces or do you want me to repeat the whole station once again? It is a 10-minute station. Yes, Zainab Iftikhar, it is a 10-minute. There's nothing like short case in MRCOG3. It's not like MRCPI. I will do that, my dear. This is MRCOG3 station and the MRCOG3 stations, they come up as the 10 minutes station in a go. Like there is no short case and there is no long case. Let's do the full station. No worries at all. So I'm talking
Sorry,
to
mom.
Annie Jones. Hi, Shainaz. How are you?
Hi, I'm fine, thank you.
Yes, my
I just have a question. Because she's on 50 and her TSH is high, is it okay if we increase to 75?
So definitely the thyroid doctor let them do. We are going to refer that to the specialist. Yeah,
Okay, thank you.
perfect. Thank you very much. All right. Hello, I'm Dr. Kaur. I'm one of the doctors in the clinic today. Am I talking to Mrs. Annie Jones, 36 years? Is it okay I call you Mrs. Annie? Thank you very much. I've gathered from your case notes that you're here today into your third pregnancy. I'm extremely sorry for your previous losses. We are here to support. At the very outset, I would like to apologize that my consultant is away because of some unavoidable circumstances, and we are here to take forward the consultation. Is it okay that I ask you questions? Yeah. Can you tell me more about the current pregnancy? Okay. All right. I see. So, Mrs. Annie, in this current pregnancy, any sickness, any vomiting, any bleeding? I see. All right. Any other concerns at all? Nothing at the moment. So did you have your initial checkup and your investigations with the midwife and the ultrasound? I see. And the baby heartbeat has been okay. All right, that's reassuring. And did you start your folic acid? Okay, all right. And you know the dose? I see. Thank you very much. So with regards to your condition, if you could tell me the details about that. And when was it diagnosed? I'm sorry to hear about this. How are you coping after that and how are your symptoms at the moment? I see. Okay. And did you get checked with your thyroid specialist recently after knowing that you're pregnant? No. Okay. We are going to refer you as early as possible if that's fine for you. Thank you very much for your cooperation. All right. So with the past two pregnancies which you've mentioned, were they medically managed or were they surgically removed? How did the management happen for the same? I see. And how was your recovery? All right. In between the pregnancies, did you have any contraception, any birth spacing, and did you get pregnant spontaneously? I see. That's reassuring. So your pregnancy, your periods were regular? Okay, all right. So when you got pregnant, you are taking medication, the 50 microgram dose, right? So was it increased? It's the same one. All right. For that also, we are going to refer you to the doctor if that's fine for you. All right. Any other medical concerns? No. Any other family history of concern which you would like me to know? I'm sorry to hear about your mother. Is she doing fine now? Was she tested and was there any other condition for which she had the clots? Nothing like that. Okay. May I double check your BMI? I see, it's 32. I'm going to document that, and we're going to take certain steps, and we would like to increase the folic acid to 5 milligrams as well, if that's fine for you. Thank you very much. Apart from this, any known allergy, please? All right, I'm going to document that, and we would avoid that for you in this pregnancy. Any personal habit like smoking or drinking alcohol? I'm sorry to ask, any recreational drugs, Mrs. Annie, at all? No. How's the support at home? And in the last few years, I know that things have been quite tough for you. So were you connected to some counselor? How had your mental health been? All right, I appreciate. Thank you very much for all this information. Anything important you would like to inform me about? Thank you. I would like to examine you in the presence of a chaperone, if that's okay for you. Thank you very much. So, Mrs. Annie, I'm here to tell you about the condition. Before I begin, I would like to know that what is your understanding about hypothyroidism? Yes. All right. So you're aware about what exactly it means, yeah? All right. I've confirmed the name and the NHS number on your reports, and it does reveal that the thyroid levels, that is, the hormone is increased. We call it as TSH, and that does mean that the thyroid hormone is reduced, and we call this condition as hypothyroidism. As you are on the correct management, but we do have certain concerns, I would like to inform you about the effects on the baby and the patient being with this condition in the pregnancy. Is that okay that I continue? Thank you very much. So for the baby, because thyroid hormone is very important for the development of the baby, it can cause some developmental defects in the baby, especially when it comes to the brain development. Yes. And the baby can have an early birth that can have the complications like difficulty in breathing once the baby is born. The baby can born earlier than the due date and can be smaller in weight as well. Are you with me? For the mother, there can be deterioration in the thyroid levels as the demand is more. We would be adjusting that. But keeping in view, this is a high risk pregnancy because of two factors, the thyroid hormone being lower and the weight to height ratio being 32. Are you following me? Now, when we consider these both, we are going to increase the folic acid, and I will take your pregnancy journey from this point onwards. Are you with me? At 8 weeks from this point, we are going to increase the folic acid to 5 milligram. Around 9 to 10 weeks, we are going to have a dating scan to date the pregnancy and see the growth following this date scan. Is that fine? We are going to have the down screening around 11 to 13 weeks. And around 20 weeks, we are going to have a detailed baby's head to toe scan for you. Is that fine for you? Now, after that, we would see if the growth assessment of the baby through the ultrasound is needed. And keeping in view the BMI, we would also like to assess you for the blood thinners if at any point in time that's needed. Is that okay for you? The first and the foremost thing now is to refer you to the thyroid doctor so that we can adjust the dose and make sure every 4 to 6 weeks till 20 weeks, we are going to have your hormone test. Yes. If it is fine, we will continue with the same dose, but if any adjustment is needed, we will be quick in doing that to avoid the complications to happen. Would that be okay for you? Thank you. Now, with regards to the pregnancy birth plan, it is going to be around 36 weeks. We would see how the things are. And as per your concern to deliver with midwife, it's very early to comment upon that. Keeping in view the BMI, keeping in view that the thyroid levels might derange in the pregnancy, we would take the safest possible choice for you. However, we will counsel you for all the pros and cons, and the final decision would be yours. Is that okay that we discuss that as the pregnancy progresses and you approach near 36 weeks? Yeah? And the plan of the birth will be in the consultant-led care if at all some complications are there, and it would be the baby monitoring. The aim to have the vaginal delivery would definitely be the choice, but depending upon how the presentation and how the pregnancy proceeds further. After the birth of the baby will be checked by the thyroid doctor, the baby would be evaluated, the baby thyroid hormones would also be checked. We would encourage you for the breastfeeding and would definitely give you the suitable birth spacing. We'll connect you to the dietitian and exercise specialist so that for the next upcoming pregnancy, the BMI can be reduced to avoid the complications. Are you with me? So for today, we would like to refer you to the thyroid specialist to evaluate the thyroid dosage for the thyroxine, and we're going to increase the folic acid dose and would like to see you in 2 to 3 weeks' time again. I would give you the patient information leaflet, connect you to the support group. If anything from our side, please do not hesitate to contact if you think that you need a counselor or any other support. This is the 24/7 hospital contact number, and we are here to support you, please. Anything you want me to repeat? Thank you for seeing me today. We are here to help you and would like to see you again in 2 to 3 weeks' time. Thank you very much, Ms. Jones, for seeing me today. All right. So this is the flow which I want from all my students. This is the empathy which I want. This is the up and down which I want. This is the tone which I want. And the choice of words should really, really be good. Thank you very much. Please do that, Chazi. Let's do it with you. I'm ready for this. Thank you thank you so much. I am grateful, guys. Can we do do's and don'ts together? Humaira, I miss you. Thank you so much, Sarak. So good to see you guys. Thank you so much. All right. So any questions, please? Anything? It was all spontaneous. So maybe if I was up and down or something, I didn't ask the blood group purposely. Please don't miss that out because it was already given it's B positive, right? Hitham, it just comes with practice. Don't feel that mentor was like this forever. It's just like, I think with the flow comes with practice, guys. The flow and the choice of words, they come with speaking more. And I'm sure that you all would be even better than when you're ready for your exam. I'm 100% sure of that. Thank you very much, Ahmed. I'm so happy to see you. Thank you very much. Oh, my love. No, Shazil. I'm a very, very tiny creature. And I'm sure that you guys enjoyed the coaching session 1, 2, 3. This is the coaching session 4. The 5th is, I think, on Wednesday or Thursday. You guys are already ready for that. But my point of view to pick up these slides and to make these tiny points for you guys and make it pictorial was that you guys are able to organize your thoughts, right? I am super proud of you guys for your efforts. I'm here, Zoya, before I go to the do's and the don'ts. Please, Zoya, please ask the question.
Dr.
Yes.
Sidra, so the new guideline says that, by the time we'll refer her to, her specialist doctor, we should tell her to self-initiate and increase the dose 2 times, like twice a week or something on the 2 days. Do we
So
do that or do we?
the thing is that she has come quite early. She's not late. So it's okay
Okay.
that we can refer because, no referring at the moment is like, making a delay in the patient's safety. Yes.
Okay, so we won't tell her to increase it, yeah?
It's better that now when she says that I've not met my doctor, it's better that we send her.
Okay.
Okay. Thank you very much. Are you there? Rosina, I love you so much. Maninder, are you there? I'm so proud of you. Can I have a big round of applause for the presenter, the participant today? All of you, please. It really is a big courage. And you know what I say that what is the first step of success? You guys keep on seeing my Instagram. You keep on seeing the motivations. Thank you, Simi. She really deserves. I always say that the first step of success is that you guys start speaking without thinking that who is listening to you. This is the first step. Thank you very much, Pagalu, my love. I'm so good to see you here. Thank you. I always say that the first step of success is when you stop thinking about that who is listening to you and you start speaking. When you have this courage, Vinu, you're already on the ladder of success. Yes, and I have full faith that if you guys can present 10 minutes, in fact more than that, you guys have a potential to correct yourself. And the mistakes which we do today, I get really happy on that because we would be repeating that stays in mind, So I'm very proud of all those who are volunteering for these coaching sessions. Come up for the next week as well. Please speak. This is for you guys. And you all, many of you are in the premium groups, in the fast track. The premium 121 is only 2 seats remaining. I'm waiting for the results. I know it's going to be packed up on the result day. 30th is a big day, guys. MRCOG Part 2 result is there for RFA. And the fast track seats already being fastly booked. It's all because of your love. But at the end of the day, we can just teach in our humble capacity. You have to speak, speak, and speak. So let's wind up, guys, on the do's and the don'ts for all the domains which I made in the morning for the MRCOG 3 SPT. Information gathering, please build an early repo. Try to use the open questions, clarify patients' ideas and concerns. As I told, please don't ignore the concerns. Please summarize the information frequently and do not speak the jargons. So do not interrupt patients' answer. Do not cut the role play. Avoid jargons, please. Do not rush through the symptoms and do not ignore her emotional cues. For example, she's like this. For example, she's like this. For example, she's anxious. Please do not ignore that. This is an empathy point. Offer her support, offer her counselor. And do not assume that she knows everything. Did you guys see when I did the station, I said, what is your knowledge about the condition you're having? Why? Because I didn't want to waste time to start from ABC. Maybe she knows more than what I want to tell her. It will save my time. Did you guys get that? This saved my time because she's already on thyroxine, so definitely she has some info about her condition. Patient safety. Mention the TSH monitoring timeline. Advise early booking visit and warn against that, that it might get up and down for herself adjusting. She has to come to the doctor. Delaying thyroid treatment is going to be risky for her. Do not overlook the adjust needs. Please make sure that she should know that postnatal also she has to come back to the initial the levels or the initial doses because the pregnancy is over. And do not give false reassurance that it's all right, you would be okay, nothing would happen. Do not try to be a good doctor, a sugar-coated doctor, and give wrong information. You have to be open, honest, and transparent giving the information. Please do not try to be sweet giving a false reassurance, okay? For communication with the patient, for all my students, please maintain eye contact, show empathy genuinely, please. Acknowledge her concerns, clearly tell her the risks, and definitely give her support and follow up. And please do not be robotic. So many times you have template and it seems that you're reading tick, 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 no ups and downs, no pitch change, you're just like reading a line. So that does affect your empathy, please. You at times dismiss the patient's feeling, which is a very, very big dip in the communication with the patient. Do not give vague reassurance, as I've mentioned, and do not be too overly technical, like, for example, we have got TSH, we have got pituitary, we have got hypothalamus. The patient's going to be confused, right? Avoid that. Don't be very technical in the communication with the patient. And do not forget that it has to be a shared decision. Again and again, I was saying one line. I mean it. That ultimately the choice would be yours where the delivery would be. See? Even I told that this would be our suggestion, but the choice would be yours after giving the pros and cons. So always remember, whenever you're appearing in RCOG, even in our CPI, guys, it's a shared decision making. So always support the choice. Always take the patient along with you. So know the trimester-wise TSH targets for the applied clinical knowledge. Please link hypothyroidism to the pregnancy risk for the applied clinical knowledge, monitoring 4 to 6 weeks till 20 weeks, and mention that adjusting at the postpartum dose. Do not confuse overt versus subclinical. Do not miss neurological risk to the fetus. It is very, very important red flag. Do not forget to adjust in the early pregnancy, as Zoya was just saying that. Do not overlook as obesity is a confounder. This goes with core. And do not ignore the guideline, please. Thank you very much. I'm so grateful for a wonderful attendance here today. Check understanding, absolutely, Rosina. Any questions, any concerns, anything you want me to repeat, anything is there, please let me know. Thank you so much, Priya, for all the hearts. Thank you, Humaira. And I'm so grateful. The ones who have just joined in the middle, The recording would be uploaded on the YouTube in another 3 to 4 hours. I will post the link in all the groups, please. You can listen to it once again. Thank you very much, Fatima Ali. Thank you so much, my dear Shivangi. Waiting for the successful results and to have all of you in the part 3 batch, my love. Thank you so much. Thank you, Sairata. FT4 needed in this. She's already on thyroxine, Neeraj, so we can ignore that. Thank you very much, Shazataha. So good to see you, my love. So Neeraj, she's already on thyroxine, so we can avoid that. Thank you very much, Sadia Mustafa. Anything, please? Thank you so much. I am so grateful for all of you being here on the recording. Yes, yes, my love. Please, I'm here for the questions.
Yes, ma'am. As
Yes,
you told that we need more for VT risk assessment, more information. But only one question: if a person is giving family history, mother is having VTE, so
So
did
did you see
we
that I
score?
asked about the condition? For example, I will give you one example. The mother had prolonged immobilization and mother had a VT history because of probably a prolonged bed rest and her personal condition. So that
Okay.
doesn't add on to the personal history for this patient. Okay.
Ma'am, actually, she told her mother has been worked up for VTE and no risk factors were found. She told actually. Yeah.
If no risk factor found, then no score
That
for
means
her.
thrombophilias and all, she has not been.
Yes, exactly. She doesn't have anything which is running in family, Anjali. Okay.
Okay.
Thank you very much. So again, the safest thing is, Anjali, to say that we are going to assess you for the blood thinners, we'll give you if needed. That's the best thing.
Okay, ma'am.
All right. Thank you very much, Aparna, my dear. Thank you so much. Thank you, Fadi. So good to see you, my love. Fadi, do present in the next YouTubes, yeah, whenever you get time. Thank you very much. I always no. Thank you so much, Nahid. I am so grateful. Thank you very much. All the Illumini all over the world, thank you so much for joining in. RFA is a big, big family, and I'm glad that you guys are so connected to each other strongly. I'm super grateful for being there. And thank you very much, Kaur, for participating today. And I'm grateful. Any questions further before we call it a day? Neeraj, next already is booked by Akanksha. Next to her, please join. Okay. So the next 2 dates are already given, please. So thank you very much, Madhabi. It's your love. It's your beautiful eyes. Thank you very much, Anjali. So Akanksha, please give your name for the next one. And next to it, Neeraj, please take it. Okay. You can message in the group and take the next one. Sure. Very, 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 very happy that you guys are volunteering, Sandhya. Please tell in a sequence that it's Akansha, it is Neeraj, and then it's you. Okay, right in the group, my dear. I'll be happy to take it further because it will keep on going after, once a week, twice a week. Okay. All right. Thank you so much. I'm grateful to the backend team for managing all this. I'm grateful to all the mentors who are participating in that. And me being a tiny CEO, a humble person, I'm extremely grateful to listen to me for this. Then again, I am super grateful to you guys for making such a strong connectivity of this RFA alumni. Best of luck from the entire team of RFA tutors. Thank you so much. Bye-bye, everybody. Take very good care. Thank you so much. Bye-bye. Thank you. Take very good care.